I think we'll go ahead and get started. Welcome to everyone, both prospective PhD students and panelists alike. My name is Elizabeth Fair. I'm the director of the PhD program in Global Health Sciences here at the University of California, San Francisco. We are thrilled to host this session for prospective applicants to the UCSF PhD program in Global Health Sciences. In the next hour, we'll hear from four senior faculty members who are in leadership positions within the Institute for Global Health Sciences and also have active and exciting research across a variety of disciplines and geographies. To orient you to the session, I will briefly introduce you to the IGHS expert panel. Then we'll have a chance to hear from each panelist individually for about 10 minutes. Towards the end of the hour, we'll come back together as a panel for a discussion and for a chance to ask some questions. So please put any questions you have for our panelists in the Q&A box, and please do keep your microphone on mute. So without further ado, I would like to introduce you to our global health expert panel. First off, we will hear from Dr. Jaime Sepulveda, the Executive Director of the UCSF Institute for Global Health Sciences and a great champion of our PhD program. Next, we'll hear from Dr. Dilys Walker, Director of the UCSF Maternal, Newborn, and Child Health Research Cooperative. Next, we'll hear from Dr. Doruk Ozgediz, Director of the UCSF Center for Global Surgery and Health Equity. And finally, we'll be joined by Dr. Jonna Mazet, Executive Director of the UC Davis One Health Institute. So we will start with you, Dr. Sepulveda. I have a couple questions. I'm going to stop sharing my screen here. Maybe if you could share with us just briefly how you got into the field of global health and describe some of either your most impactful work or contributions that are most meaningful to you. Dr. Sepulveda.
Thank you so much, Elizabeth, for the opportunity to chat with prospective candidates for our PhD program. I was born and raised in Mexico City, where I did my medical school training. Afterwards, I went to Harvard to do an MPH and a PhD. How did I get into global health? I think the fair answer is that it was a little bit of serendipity. When I got into medical school, I knew I didn't want to do clinical sciences, clinical practice, but I was very, very keen to do research. And throughout my medical school years, I was a teaching assistant and also a research assistant doing neurosciences. When I finished medical school, I intended and was admitted at the Mayo Clinic to do a PhD in neurosciences. But you know what? Two key conversations with mentors led me to consider public health as a different track. And just I gave it a try, visited a few schools, went to the Harvard School of Public Health for interviews, and I knew that's what I wanted to do. So public health has been my field, and international health my concentration. In those years, in the late 70s, early 80s, we didn't talk about global health. The term had not been coined yet to be applied to what we do now. So after I did my MPH and the PhD in the field of population sciences and international health, I was lucky to have opportunities in Mexico at the Ministry of Health. So before I go into talking more about myself, something I don't feel very comfortable with, I just want to emphasize that the combination of having good mentors, of course, working hard, but also good luck, that combination is what might bring the best opportunities for a career in global health. And increasingly, I would say that you do need a PhD in order to reach those levels of influence, either in research or practice, that are needed. I would also say that this is the best of times to work in the field of global health. With COVID, with everything that is happening in climate change, what is happening in terms of policies and politics around global health, architecture, financing, governance, I think this is the best of times to concentrate in global health. So in Mexico, when I finished my PhD, I returned and worked at the Ministry of Health in several positions, first as chief epidemiologist at the Ministry of Health, and then as vice minister 6 years later. And in that positions, I had to do a lot with the Centers for Disease Control, with the Pan American Health Organization, with the WHO, and I represented Mexico for almost 20 years before the World Health Assembly. So I had a lot of exposure to international organizations and global health work. When I finished my term at the Ministry of Health, I was appointed Dean of the School of Public Health of Mexico. And there, I was able to create the PhD program at the Institute. And we started doing a lot of international health work, collaborating with universities both in the US, Europe, and the rest of Latin America. So I would say that all of my professional career has been devoted to what first was known as international health, and since the late 1990s, global health. And had to do a lot with international organizations then, and we still do a lot of that at the Institute for Global Health Sciences at UCSF. Let me say that our institute was the first academic entity in the US to use global health as part of the name. Sir Richard Fitcham created the Institute of Global Health in 1999. And again, that was the first time global health was used in an academic institution. Our master's in global health was the first in the country. So UCSF has had more than 20 years of working in the field of global health with many prominent faculty and a lot of accumulated experience working in the global south. I would turn to the second question. What are the contributions I personally feel the most proud of? I would say in Mexico, creating a strong epidemiological surveillance system with the national health and nutrition surveys. So that is creating a health information system on a national scale for a country of over 100 million people. So that's one. Second is creating the National AIDS Council very early on in 1986. And that led to a very aggressive HIV prevention campaign. Mexico is now, besides Cuba, the country in the Western Hemisphere with the lowest HIV prevalence. And that was a consequence of acting early and acting aggressively. Third piece is creating the universal vaccination program that led to the eradication of polio in Mexico and later of measles and other vaccine preventable diseases. So that was um, a major success. When I moved to the Bill and Melinda Gates Foundation, creating the Mesoamerica Health Initiative, bringing all 8 countries from Mexico to Panama, focusing on one single set of priorities in the most vulnerable population, the bottom quintile of the population, with cost effectiveness interventions, and bringing funds from the Gates Foundation, from the Slim Foundation, from others. Almost $300 million were raised, with 8 heads of state signing to a common regional approach to maternal and child health. That's probably the one that has been the hardest and the most impactful. At UCSF, I think what I feel good about is about creating the space of Mission Hall. That was a hard one, bringing the money to have our own building. And then, of course, bringing some of the best experts, recruiting excellent people to the team. And finally, I also feel very good about having created, along with a team, the PhD program. So I would list those as achievements and things I feel proud of. But back to you, Elizabeth.
Fantastic. Thank you, Jaime. Very interesting. I'm sure you're going to get lots of questions about your career in so many different areas. And I know that's just a tip of the iceberg, but thank you for sharing a snapshot for us. Next, we'll move to Dr. Dilys Walker and ask Dilys if you could answer the same questions. Just share with us a little bit about how you got into the field of global health, and talk about a little bit about either your most impactful work or contributions that are most meaningful to you in global health.
Great, thanks, Elizabeth. And I'm not sure if it was fair for you to put me right after Jaime in terms of that list of accomplishments, and if that was just the tip of the iceberg. Whoa. Anyway, so I'll share with you my story, which will maybe make people realize that there are also paths that are, equally rewarding and important, but maybe not quite as globally impactful. So that's really exciting. So let me tell you my story. I raced through undergraduate and right into medical school, so clear that I wanted to be a doctor. And then I hit my wall in 3rd year of medical school when we were all forced to decide, so what kind of doctor do you want to be? And I really didn't know what kind of doctor I wanted to be. And I also had a real itch to figure out what was going on in the world outside my own borders. And I think it was more about having had a very sort of sheltered and privileged upbringing and recognition that if I wanted to be an effective doctor, I really needed to get a sense of what was out in the bigger, broader world. So I decided to take a year off med school. This was pre-internet, so I wrote many of those blue aerograms. And I went to the student offices and saw where any medical students had gone and done any sort of clinical rotations. And I must have written 100 of those blue aerograms and waited for 3 months for any kind of response to come back, and managed to kind of put together a year abroad of what I admit now was entirely medical tourism. So I took off and I thought, okay, I'm going to go and, now I've had my 3rd year of medical school, I can go out and do something meaningful in this big, broad world. Well, that was pretty quickly clear that that wasn't going to happen. And it really was medical tourism. And I'll never forget sort of spending 3 months in a small missionary hospital in Kenya, where I immediately found myself drawn towards the maternity ward. And I found myself being the one that was called in the middle of the night to go help these women in labor. And it struck me how odd it was that here I was, a 3rd year medical student, and they were calling me to care for these women in labor. And there felt something terribly wrong about that I was considered the most capable person in that environment. And I was also keenly aware, as I was there and in many of the other settings I spent that year, that in any of the facilities I worked, it was pretty consistently the maternity wards that were the worst places. They were the most understaffed, they had the fewest resources, they were the least kept up, most crowded, and the sort of inequities within the global space just really hit me that you know, birthing mothers, their reproductive needs were really, and this was in the late 80s, were really at the bottom of any priority list. So I came back sort of with the decision that I really wanted to do obstetrics and gynecology, think about reproductive health on a global level, recognizing that what I had done really wasn't helping anybody anywhere, and that maybe as my career evolved, I might be able to transition that into something that actually could be meaningful, or at least those experiences. So I went and did my OBGYN residency. I decided at the end of my OBGYN residency, I would do a fellowship, the Robert Wood Johnson Clinical Scholars Fellowship. And I wrote my personal statement about how I was going to do global work, particularly around family planning, reproductive choices. And I came to UCSF and I interviewed, and I went to a number of other universities and interviewed. I went back to Philadelphia where I was doing my residency, and about a week later got a letter saying, sorry, you're disqualified. So these things, serendipity plays a big role in one's choices. And they said I was disqualified because it was clear I did not want to do domestic work, and they only wanted to fund fellows that were interested in domestic work. So I was a bit left like, how am I going to get to where I want to go? And I shortly thereafter received a letter from Phil Darney here at UCSF, who was putting together the fellowship in family planning. And he really wanted it to have a global sort of perspective to it. And he said, Dilys, why don't you be our first family planning fellow? So I said, okay, why not? So I did the fellowship, which really is sort of provided some of the sort of research, implementation research skills that I needed to add to my clinical knowledge and capacity. And then I kind of fast forward, because then we can kind of transition into sort of how what other formative experiences and roles. And that fast forward is to spending over a decade in Mexico under the leadership of Jaime Sepulveda there, and working at the National Institute for Public Health for the Mexican government on problems in Mexico, where it really made me understand also the nuances of the roles as an outsider, insider, and straddling those outsider-insider worlds. The number of conversations I had with, Mexican academic public health researchers, and their annoyance at the way that some of these American institutions came down there and thought they knew best about how to run trials and what they were going to discover. And it really allowed me to build an appreciation for what my role in a global research meant, and how to do that with humility and respect. In terms of the greatest impact, I think that some of the work I did in Mexico was extremely formative. I'm very proud of the work I did to support professional midwifery there. It was a time when there was no such thing as midwives. There were doctors and there were nurses, and all babies were being delivered by doctors. And we did a trial there that compared the care between doctors and professional midwives, which was later used in the legislature to support opening up the professional codes again for midwifery. So I feel very sort of proud that work actually moved legislation, which opened up professional midwifery, which provided an alternative model of care for women in Mexico, and that is sort of broader. That also kind of, was during the time of the MDGs, and Mexico was not reaching their MDG goals. And I was sort of called in to help with a strategy to address why women in Mexico were still dying at rates much greater than they had hoped for, expected, and were working towards with the MDGs. It quickly became clear that those mothers and babies were dying, mothers particularly, were not dying on the way to the hospital, or they weren't not getting to the hospital. Most of them were going to hospitals and not getting the care they needed. So that led to developing a response to that, which is called Pronto, which is a training program that introduces highly realistic simulation, very low cost in situ, and team training to improve maternal and newborn outcomes in intrapartum care. That program, which started in Mexico, funded by Mexican dollars, by this trial to prove that it worked, funded by Mexican dollars, has now since grown enormously, founded an NGO, which sort of is the implementing partner for these simulation and team training programs. And we're in 10, 12 countries now. And it's allowed me to straddle this role of, I'm an academic doing implementation research, particularly on quality of care around the time of birth. I'm a clinician. I still do clinical work at UCSF. And I have a hand in the implementation and the importance of implementation and understanding implementation in multiple contexts. So that has kind of gotten me to where I am now. And sort of the next frontier is kind of merging this sort of simulation team training work with a new technology that we call virtual mentor, which is a sort of Siri, Alexa, that providers can call on in the middle of an obstetric emergency to help guide them through what's going on. And we're busy looking for funding and implementing. We're doing a sort of early piloting in Madagascar, and that's going to be the sort of next frontier, I think, of our work. And then the very last point is kind of this, I find it really rewarding to be transitioning from sort of not only sort of being the lead PI on these projects, but also an important role I find is sort of supporting early mid-career academicians and building a real team that cares about maternal, newborn, reproductive health on a global scale. And that has sort of really been an exciting area for the past 4 or 5 years at UCSF for me. I think I'll leave it there. Pass it back to you.
Great, thank you, Dilys. I know a little bit about your work now, but really appreciate your honest description of your path through medicine in the early days. And we talk a lot about sort of if you don't see it, build it, and the hustle that's involved in defining your career in global health. So thank you for sharing that. Let's stay in the clinical world, and I will pass the mic over to Dr. Doruk Ozgediz. Doruk, can I ask you the same questions? Share a little bit with us about your path into global health and some of the most rewarding, impactful work that you're doing currently or recently.
Yeah, thanks a lot, Elizabeth. And really, it's great to join this panel and even learn more about everyone that I knew before. I actually moved back and forth between Turkey and the US growing up. So I think that always kind of caused me to think about differences between countries and where we are in the world, just in my own kind of personal life and my family. I studied economics as an undergrad, and I was convinced that that was like the most valuable route to social change, and then got interested in medicine, and then came to UCSF for medical school in the mid-90s, planning to probably do primary care as a specialty. I was especially interested in Chinese medicine and had spent some time in China, and that looked like the route that I was probably going to go. And as a med student, found myself instead very drawn to surgery and surgical disciplines, which was really hard for me to reconcile. And to make things even more complicated, I had this interest in international health and kind of health equity. And I think one of the great things about UCSF is that it's such a big part of the mission. It's always been such a big part of the mission, both in our own backyard here in the US, but also beyond our borders. And I was very influenced by that, but was very drawn to becoming a surgeon. And most of the people that I asked for about advice around that time said, if you're really interested in international health, you really can't become a surgeon. And really what you ought to do is get an MPH and go into infectious disease, because that's really where all the funding is. And really the only thing you could do as a surgeon is surgical missions. That's basically it. So I kind of just didn't listen to that advice. And I followed what my passion was, which was, trying to become a surgeon. And I talked to, a few people that were doing things that seem like would be somewhere I might want to be, in the ballpark 10 to 20 years down the line. But I have to say, there weren't many. So I was fortunate to get into the residency program here, which is, very broad-based. And as residents, we have the option, many residents in general surgery, to take scholarly time. We were very encouraged at that time to join a lab, because that was the way that you became an academic surgeon. And instead, I wanted to do a master's in public health, which also was an uphill battle, because that wasn't something that surgeons typically did. You go to the operating, you operate on a patient, and that's basically kind of like the end of it. So you're supposed to kind of learn about those diseases. But my interest really was in kind of translating these clinical skills I was getting to the population level and learning more about that. So I did that as a resident, did a master's in public health. I did that in London at the London School for Hygiene and Tropical Medicine. And which was a great program, and I learned a lot from my colleagues. And simultaneously, this is now 18 years ago, started a linkage with Uganda, which has been the main place that I have been involved in as a surgeon over my career. Now 18 years down the line, I wouldn't say that there was any strategic plan to like have a 20-year relationship, but as probably many people would say on the call, and I'm sure some of the students who are interested in these experiences, you make these experiences based on your relationships with people and experiences that grow and lead to other opportunities. So that was really critical and also very humbling. I went to Uganda actually largely through our linkages in malaria, and discovered that really there was not as much attention being paid to surgical diseases that were of critical importance on the ground. I felt at that point as a surgical resident, pretty ill-equipped to actually have an impact. And I think one of the biggest questions that I had and that I still have is, where should we be putting our funds and our efforts? What has the greatest impact? And largely the things that I think drive that are the local priorities. So I made a decision at that point, as we started our relationship with Uganda, that I would come back and work after I finished my training. So after I did my general surgery training and boards, I went back and worked there for a year as a general surgeon. This is now 13 years ago. And really the most pressing local need was around workforce and workforce training. So I worked as a clinician and as a teacher working with Ugandan surgical trainees and also with American surgical trainees that were coming over there. I had intent at that point to train as a pediatric surgeon because it's a very broad field, and in the low-income world, there are a lot of children, up to half the population in many countries. So in that year before I did my ped surgery training, I worked and lived in Uganda. We started a nonprofit called Global Partners in Anesthesia and Surgery, and a lot of our efforts went towards, in the last 10 to 15 years, supporting local surgeons through the surgical specialties and anesthesia, and it kind of, which dovetails into kind of meaningful contributions. That was kind of, I think, regarded as a risky investment. It was not something that came through an academic group, but more from philanthropy. But about 90 to 100% of the trainees who we supported are in country and are leading programs now, 15, 20 years down the line. And I'm just so happy that they're really kind of running programs in their own country. After I finished my training as a pediatric surgeon, I made a commitment that I would have a career that would split between clinical care and tackling some of these bigger issues in population health that related to surgery. And for the last 10 years, I've spent about 3 months a year having an academic base in the US. I only recently returned to UCSF. Previous to that, I was at Yale, but would mostly spend my international time in Uganda. And a lot of that time has been spent helping the local teams, again, develop and strengthen their workforce, but also strengthen the evaluation of interventions to kind of improve outcomes, and then trying to see what we can learn about that and scale it to other places. In the last several years, about 5 years, I've been part of a group called the Global Initiative for Children's Surgery, which has brought together many different providers across the surgical disciplines and anesthesia and nursing that care for children with surgical problems. That group, which is also composed of many NGOs, has really advocated for greater global investment in surgical care. One of the really active groups that we're partnered with is a group called Kids OR, which is a charity in the UK that's making a substantial investment in operating rooms in low-income countries, with a plan over the next decade to develop 120 centers of excellence for children's surgery in Africa. And we're very closely linked with them. I guess I would say, the biggest and the most meaningful things for me have been relationships. So, relationships with international providers who have humbled me in many ways. And I would say, because a lot of my work internationally still is as a clinician, as a teacher, but I learn just as much from my colleagues locally about how they manage limited resources, and too often we don't bring those lessons back here. So there's just a tremendous amount to bring back. That's a big kind of black box. I also think we have a lot to learn about the impact of our interventions in education and training in many of these settings. And I would say for the students who are interested in these types of programs, two things about our center here. One is that we recently changed our name. And we actually dropped the word global from the name, because many of our faculty are very invested in efforts here. And there has generally, I think, been a big question about what global means anymore, and whether it means only international or it means domestic. And we've all been through that transition 10, 15 years ago from international health to global health. But really, for many people, it just means exclusively international. And I think the focus of a lot of the people here is around equity, regardless of geography. So that's one thing that I think is important for people to think about, what that means to them. And then I would say just that there are a wealth of faculty here across the surgery and anesthesia and nursing disciplines who have been invested in advancing care for surgical conditions around the world, from here to all around the world, and are an incredible resource to work with, to study with, and to learn from. So thanks a lot.
Thank you, Doruk. That was a lot of information distilled in a short amount of time. I appreciate it, and appreciate your sharing your non-traditional but very high impact path through as a surgeon working in global health, and just thinking about, even hopefully some of the participants on the phone, even if you're not an expert in surgery or a surgeon, the areas of research that you could collaborate on that you just highlighted, I think are vast. So thank you for sharing that. Last but not least, we have Dr. Jonna Mazet. We're moving from clinical worlds to veterinary one health worlds. Jonna, thank you for joining us. And I introduced you at the beginning. I know you're joining us a little bit late, but wanted to just ask you, maybe spend about 10 minutes sharing your path into global health and some of the most meaningful, impactful work that you've been doing recently in the field of global health.
Sure, thank you. And as you mentioned, I am, oh, that's spooky. I didn't do that. As you mentioned, I am a veterinarian. My first doctoral degree is in veterinary medicine, but I am also an epidemiologist. And I originally trained in epidemiology, joint program looking at human and animal health. But I originally trained thinking that I would use that almost exclusively for wildlife health and population medicine. And as I was working in my first sort of real research jobs, I was working on trying to save the sea otter, the California sea otter. And as we think about, all global health, starts somewhere. For me, my path on global health really started here in California. I found that the sea otters were dying of some of the same diseases that my friends and colleagues were dying of that had HIV/AIDS. And so that really brought home to me that we as humans are putting ourselves at risk by the sort of heavy-footed treading we do on the earth that puts susceptible species as well as our susceptible friends and family members at risk from emerging health threats. So as I was working on the sea otter work, I was also developing a center called the Wildlife Health Center at UC Davis. And the Wildlife Health Center started to grow and was successful, and we were getting lots of requests to engage internationally. And for me, I felt very strongly from the beginning that I didn't want to, come in as any kind of, savior from the West or the North, and that it didn't make sense to partner just for the sake of partnering and putting our names on MOUs and things. And those of you who haven't experienced this, you will see over time that many universities, including our own, like to show their relationships, and often those aren't substantive. They're not actually, really working towards some common good. And so I was pretty. I don't want to say cynical. I was still quite junior, but I was probably diligent in the exploration of the opportunities that might be actually productive for the world and for our own activities. And at one point in exploring those different international engagements, colleagues in Tanzania asked if we would come to Tanzania to look at water issues. And the water issues were extreme. And in fact, rivers, huge rivers that provided most of the Great Ruaha River specifically, that provided most of the hydroelectric power and much of the necessary water for drinking and irrigation and bathing for the country, were drying more and more. And for me, that was certainly a very interesting One Health problem, that this drying river could bring animals and people together in more and more concentrated water sources as the river dried, allowing people and animals to be exposed to pathogens, but also reducing livelihoods from irrigating upstream and power for industry in Dar es Salaam. And so there were environmental components, human and animal health components, and even plant health components. And getting involved in Tanzania also meant for me starting to learn how to engage with communities and really understand better what kind of role I could play as a partner rather than a leader, because I'd certainly been trained to be a leader, not a partner, throughout my two doctoral dissertations or paths. So I think that was incredibly formative for me on how I wanted to engage, and learned right then that everything begins and ends with communities. And throughout the years, I'm still engaged there. We ended up developing a health for animals and livelihood improvement project looking at zoonotic diseases. It's where I first met you, or how I first met you. We barely met, but we first did TV projects together at that site. And we were able to move from, very small pilot funding to large scale USAID and NIH funding to really dive deeply into issues that the communities were facing and felt were important. And the communities let us know when we were diving into issues that they didn't think were important. And that was an important lesson as well. In the end, the river's still drying. People are still exposed to zoonotic diseases and primarily human diseases like non-zoonotic TB. But we're chipping away. We're seeing small behavior change because we work with the communities there. So communities that never boiled their milk don't boil their milk for everybody, but they boil their milk for the babies and the old people, and they send matches to boil water when the young men take the cattle out to graze far from home and have to collect water. So the pastoralists there taught us a lot of things, and together we explored and saw some change. And behavior change is another thing that I think is so critically important and hard. And why I'm really thrilled to be part of this program is that I think that it's really leading the way in mixed methods and looking at all sides of problems. And so I'm just thrilled to be with you. Over time, my career's changed, and I've really gone kind of to a global scale and have managed projects in multiple countries, sometimes more than 30 at a time, in Southeast Asia, South Asia, Africa, and Latin America. I've been able to engage all the way from working on the ground, still capturing wildlife, but also sampling people, working again with communities, and being so shocked at how generous individuals in those communities have been with their personal information and their personal fluids and samples that they're willing to take for us at just a simple request. And really, I think, to go back to something Dilys said, because we approach it differently in that we hear out the concerns and then bring the data back. So with our PREDICT project, we've been able to be on the forefront of emerging infectious diseases, including coronaviruses, and that's made this last year really, I guess I'll just say, interesting. But now working on workforce education in those same regions, and really strengthening the One Health approach to be considering the interconnections of human, animal, and environmental issues, sometimes plant issues. We need to do more on the plant side, but also keeping that community base in mind. So it's very rewarding work.
Great, thank you.
Yeah.
I know that's just scratching the surface of your One Health work, but I really appreciate you highlighting the importance of partnerships and relationships, and I think you're a model of that, and the importance of that in global health work. And I think everyone who is, all panelists touched on that a little bit, and I'd actually like to pursue that a little bit more. So perhaps I can bring the 4 panelists together for one last question, and then we'll open it up to the audience. And as I said, it is about partnerships, relationships. I know all of you mentioned in your own personal narratives and stories the importance of mentoring and long-lasting relationships in this kind of work, and wonder if you can share a little bit about either how you select students to work with, or your experience working with doctoral students, whether it's this program or other programs. I know you all have a huge amount of experience working with students, and given the audience here today is, potential applicants to this program, if you could talk a little bit about your experience mentoring, how you approach it, thoughts.
Do you want us to go in the same order or randomly?
Randomly. Would you like to start, Jaime?
I'll give it a try. I think creating human capital is indispensable if we're going to make any progress in public health, global health, international health, health equity, all of those areas that we're interested in. I have been lucky to mentor dozens of young people, though not necessarily PhD students. And I will make a slight differentiation here. When I was in Mexico in policy positions, I really didn't have an academic responsibility until I became dean years later. But what I did in order to create human capital was to send a lot of people to the best universities to get masters and PhDs in public health. And as a consequence, we created kind of a cohort, a school of new blood and new thinking with competences and skills that were very necessary, cascading down. So that was very fortunate, and we were able to send many, many people to the best universities, and now they're back in positions of great responsibility. So that is one way of creating capital, human capital. In terms of how to select students, I think both in Mexico and here, I have been fascinated by how incredibly smart, much smarter than in my generation, students are. And there's a limit of how many I can take under my supervision, but I try to select people that are truly passionate, truly committed to health equity. And so far, I can say I have been extremely lucky to have had wonderful students that are pursuing great careers.
Fantastic. Thank you, Jaime. Shall we go in order? Dilys, may I ask you to comment next?
Sure. I'll try to be very brief. And I will kind of flip it, because the way I like to think of it is that the students are selecting me. I'm not really selecting them. And I think that prospective students really need to be thinking of themselves in the driver's seat of this, and the driver's seat of it's a two-way street. The student really needs to think about what they need and how they're going to get what they need. And they need to know enough about me to know whether there's some aspect of that career development that I can provide. And I need to know enough about that student to know if there's something that I'm hearing that that student might need that is a good fit. So that does require, quite a deep understanding of what that student's sort of short-term, I need to develop these skills, like that's one area. Is it more of a longer-term relationship that you can tell that there's something about that student's career path that you could actually be helpful, instrumental, and advise a lot in? Or is it, thirdly, something about the topic area that you have a deep understanding about that will really help move that student towards their expertise? And I think it's a little bit different when you're talking about master's and PhD students, because PhD students really are diving into something that is their own, and it's really important that which aspects of that they own fully and develop fully. I'll leave it there.
Maybe I could echo, so passion, and I think just awareness of motivation. So just getting a sense, really kind of meeting students, what they're most excited about and where that comes from. And then secondly, I think, and in a sense, maybe where they're trying to go, and what skills they have now, and which ones they kind of want to expand. So some kind of honest assessment of that. And then I would say maybe, the biggest one is balancing individual goals with like the team / the needs on the ground or in the community, and the ability to kind of work with others and use that experience of learning to lift all boats, which sometimes is really hard to do when you're trying to achieve a scholarly goal. So I think that's for me one of the most important things, especially in trying to pursue research relationships that are equitable and not colonial, and that are yielding really impactful information at the same time.
Should I go? Yeah, okay. So for me, I echo what everybody said, and I want to make sure I let you know that I really find student engagement incredibly inspiring. And I think a lot of the growth in my own career has come from what I've learned from and with my mentees. But I'll also be a little more probably pragmatic with you. And that is that I often don't choose students except after I get to know them pretty well. And that's because I want to make sure that they have a good expectation of what I'm likely to deliver to them, and that I also understand their preferred engagement strategy. How much do they want to meet with me? And does that match with how much time I can give them? How mature is that student? Some students want, to shadow and be one-on-one, and some prefer to go work for a month and come back with the results and talk about the next direction. So making sure that that student's needs match up really well with what I am likely to be able to deliver in their educational experience is super important to me. And chemistry is important because you're choosing a long-term relationship. So just getting an email or seeing a CV or having one meeting is not really how I do it. In fact, the majority of my students, I think I've had 80 mentees, graduate student mentees over my career so far. And the majority of them have come through a training program that I have loved to be engaged with. That's delivered often in Tanzania with that Hali project, but used to be an EnviroVet program primarily for vets and other disciplines, but it was hugely heavy on vets, and we evolved that over time to be what's called the RX One Health, or prescription. One Health is the prescription for the program. That's a multi-week intensive summer course. Where we bring people from all different disciplines in all different countries together. And many of my mentees has been because I've lived and camped and done all those things with them and know whether or not we click.
Thank you very much. I have a comment, but before I add to that, I want to encourage anyone, we're going to move to the question and answer. So if you have any questions, please put them in the Q&A chat and we will try to get to them or triage them to the appropriate faculty member here. While you're all thinking of that, I think all of your thoughts on mentorship is spot on. And I would add one more that I find very rewarding working with students is also the opportunity students are as connectors. So, it's getting to know other faculty members via students. And we talk a lot about team mentorship in this PhD program, and especially in global health, where you're able to draw on such different kinds of disciplines. You need to draw on different disciplines and different sets of expertise. So it's such a fantastic opportunity to connect students with mentors who may not have typically worked together, but focused around a certain student's project or focal area. It actually brings different kinds of faculty together. That's a very rewarding thing, I think, that we often see. Okay, so we're starting to get some questions here. Let me see if I can send these. So one person asked, how significantly Have your global health work opportunities or relationships changed, if at all, in the current political climate? Would anyone, I know it's, these are strange times we live in. Would anyone like to take a stab at that question?
Quick comment. I think the current political climate is pretty depressing in many places, particularly on COVID-19. We have seen that nativist, populist presidents or prime ministers, and I can think of so many that have led very poorly. And these are mostly men, populists, that are anti-science. So it is difficult, starting with Trump and thinking of Boris Johnson, going to Modi, going to Putin, going to López Obrador, going to Jair Bolsonaro. Those countries are the countries that are doing the worst in terms of COVID response. And if you look at countries led by women, Taiwan, New Zealand, Germany, Norway, those are the countries that are doing the best. So that is just one reflection about the current political climate. And I think that might provide the need of having more women in positions of leadership and training more and more women in the field of global health so that they can reach positions of leadership and decision making, I think will be fundamental. So how that changes the opportunities and relations, I think we have to make sure that by working more on diversity, equity, and inclusion, but seriously, we will lead to better opportunities in research and training.
I can make a quick comment, then I have to jump to another meeting, but I think the health climate has changed what we can do in global health. Some for the worse, for sure, because we're all home, and hopefully, if we're good models, and not able to engage in person, and some of our field and lab activities can't happen. From a political side, I'd just say that this is the first time in my career that I've ever had nationalistic political boundaries. Well, I shouldn't go that far. I've been kicked out of countries for that, so that had nothing to do with me. But really had research just stopped because of politics intervening directly. I guess it's the first time that it came from the U.S. side. And in fact, even had work overall, the whole body of my work threatened because political powers didn't like what I was saying about science. So, so that's dramatic, and that's different in our country. And yeah, hope y'all vote.
Thank you, Jonna. I know we're at the 2 o'clock hour, so I'm actually going to thank you all for participating in this panel. It was fantastic to hear more about your work in global health, the exciting research being done at UCSF and with our colleagues. I wanted to share that there is one more information session that we'll be hosting on November 12th. The details are on our website, with a chance to talk with current PhD students in the program. So if you're interested in that, please tune in as well. And again, a sincere thank you for everyone for tuning in. It was a great group of speakers, and we really appreciate hearing about the diverse pathways into and through global health.